If not, that's good. If so, I would just like to point out a few notes about that kind of presentation. My intention is to, through case presentations, to emphasize the importance of the ECG, the pediatric ECG, in the initial assessment and initial diagnosis of some, not all, congenital heart disease. During that presentation, we will encounter cases where the ECG was a very diagnostic key point, and some other cases where the ECG helped to direct the diagnosis. And in some cases, the ECG is not at all specific for the diagnosis. This is the focus of my presentation. Again, I emphasize that diagnosis of congenital heart disease is by echocardiography. So the ECG does not exclude or avert the role of echocardiography. But again, the third point, for the pediatrician in the newborn care unit upon delivery, some situations impel that the pediatrician should think or is suspecting the presence of congenital heart disease. Until he gets an echo done, or if he wants to get an echo done, the ECG, and later on we might focus on the X-rays. The ECG and the X-ray can help him very well in increasing the suspicion, in even making a very close preliminary diagnosis. Now for the case number 11, we have gone through that case, but I would like to see again the case. Let me remind you that I'm presenting the pertinent clinical findings of a case, the pertinent, not all, the pertinent, and I'm not hiding clues. After the pertinent clinical findings are presented, we are going to see the ECG of that case. You will have about few seconds, half a minute, or maybe more to analyze the ECG. Let me emphasize that the ECG analysis can be made not in a systematic, in a very thorough way, just point to the positive findings that you might observe. And then after seeing the ECG findings, we are going to think about the possible diagnosis of the case. This is case number 11. Let us read it. Most of the working pediatricians might have guessed what may be that congenital heart disease from the clinical combined with radiologic findings. Let us look at the ECG. Remember, this is a 9 months old infant, an 11 months old infant. All right. That ECG shows an electrical axis of 120 to 150, which is at that age probably not within normal range. An RS pattern in V1, an RS ratio in V1 about 9, RV1 pattern, RV1, the amplitude is about 15 millimeters, and an SV6 pattern, and the S in V6 is about 9 millimeters. The T wave is inverted in V1, applied V2 to V6. These are the pertinent findings, and such findings clearly demonstrate a right axis deviation combined with right ventricular overload. In combination with the clinical data, we might easily make the diagnosis. Let me emphasize again that in the first presentation last month, we looked at congenital heart disease based on the presence or absence of cyanosis or of potential cyanosis. The radiologic findings, either in relation to the lung vascularity, either normal, increased, or reduced lung vascularity, basic findings, and the ECG findings in regards to dominance, ventricular dominance, either right, left, combined, or no ventricular dominance. In that case, we have oligemic lungs, right ventricular dominance, and right axis deviation, and clearly this is a case of pulmonary stenosis. The hallmarks in diagnosis are the right dominance, the right ventricular dominance. The right ventricular dominance is not very specific for pulmonary stenosis, but it can be seen and detected in any type of congenital heart disease with RVOT obstruction. This is an interesting table showing the classification of degree of pulmonary stenosis for basic ECG criteria, the axis, the QRS pattern in V1, the R in V1, and the T waves. I will not repeat what is present in that table, but it shows clearly that in the newborn unit, you can very easily make that diagnosis and classify the severity of pulmonary stenosis before performing the echocardiography. You will send your patient for echo, putting on your request a near accurate diagnosis. The right axis deviation in association with congenital heart disease directs us to one of these three groups of congenital heart disease: pulmonary stenosis and the rest of the group of RVOT obstruction, tetralogy of Fallot with its variants, and definitely the Eisenmenger syndrome. Let us look at case number 12. Again, an 11 months old infant. Read the text. Some of you or many of you have put notes on the application يعني of the Zoom application. Made notes about the ECG findings. I will ask you to close your mics. فضلك يا دكتور اقفل المايك. So my advice is to have a small piece of paper and a pen to put your notes and to test yourself. All right, basically this is the same case. And this is the ECG of that other case. Have a look, put your comments, and think more deeply. All right, just for the sake of time, the axis here is about 210 to 240. Some people and some reference books prefer to put that axis by the minus sign. So it is minus 30 to minus 60. Same thing. It depends on how you see that axis, whether it deviated from the right side to the extreme quadrant or from the left side to the extreme quadrant. And our excuse me. Excuse me. All right. The RR dash pattern in V1 is very clear, something like a bundle branch block. The pattern in V6 is R deep S, little bit accepted, but the R is small, and the RS ratio in V6 is less than 1, which is not normal. The findings are of an extreme axis deviation, right ventricular overload, and incomplete right bundle branch block. Really, combined with the findings, the clinical findings of pulmonary stenosis, like we have seen, that ECG is very characteristic of pulmonary stenosis in association with the Noonan syndrome. The extreme axis deviation and the features of right bundle branch block in ECG. And such ECG findings occur regardless of the severity of pulmonary stenosis in Noonan syndrome. Noonan syndrome is not a common dysmorphic or chromosomal genetic syndrome, but it is an occurrence. I personally see Noonan syndrome 2 or 3 times per year in association with congenital heart disease. Extreme axis deviation occurs in congenital heart disease very uncommonly, but it occurs in those 3 situations. And again, if you are in the newborn unit and your ECG or the ECG of the patient shows extreme axis deviation, think about one of those 3 conditions. A reminder about the types, anatomical types or pathological types of RVOT obstruction. These are, every one of us should be aware of them and think congenital heart disease that way. The 5th type, peripheral pulmonary artery stenosis, does not cause either ECG or radiologic changes unless it is bilateral and moderately severe. And this occurs. And if you find it isolated or in association with pulmonary stenosis, think about the Alagille syndrome, congenital heart disease in association with neonatal jaundice, conjugated neonatal jaundice. Now the case number 13. So this is basically a symptomatic infant, 3 months old infant with failure to thrive. The murmur apparently is not specific, ambiguous systolic precordial murmur. The apical impulse is prominent, alerting us towards some kind of ventricular hyperkinetic states or even hypertrophy. The lung vascularity is normal, so there is no possibly a shunt, neither an RVOT obstruction. And the CT ratio is increased for that age. Maximum would be 6. So there is a ventricular dilatation or hypertrophy. This is his ECG. All right. The axis is minus, oh, excuse me. Yes, it is minus 30 to minus 60 degrees leftward. The complexes, the QRS complexes are a little bit wide for an infant 3 months of age, up to 0.1 second. RS ratio in V1 less than 1, which is not normal, that age. SV1 plus RV6 amplitudes are 40 millimeters, and we all agree that 38 millimeters is the cutoff level. 40 millimeter will be borderline, depending on where the leads are placed. And this is a difficulty in that case. But in combination with the wide QRS complexes, we should not take the high amplitude as normal. The T wave is upright V1 to V4, inverted V5 to V6, and this is not a normal T wave pattern for infants. Basically, the findings are left axis deviation and left ventricular overload. I think, first, this is a very interesting ECG in an infant, 3 months old. It could be a very normal ECG in an adult, but in an infant 3 months old, it is not normal. The congenital heart disease is coarctation of the aorta, as many of us has suspected. The hallmarks are left ventricular dominance in association with normal pulmonary vascularity. That combine طبعا in an acyanotic infant, يعني we are still talking about acyanotic groups. That combination of left ventricular dominance with normal vascularity directs usually us to some very limited types of congenital heart disease. Among them is the group of LVOT obstruction group. Definitely the palpation of the femoral pulse is a clue to that diagnosis, and this is the point which was omitted in that case, but really not intentionally. It was difficult to examine him. So let us come to the case number 14. Please read and take your time. A near easy diagnosis for the pediatricians working in the field. This 3-year-old girl have a history of near fainting. Near fainting in association with congenital heart disease or fainting syncope with congenital heart disease should direct us towards a group or a limited number of groups, including one of them LVOT obstructions, cardiomyopathies, and very few others. She is acyanotic, by the way. She is underweight. Peripheral pulses are weak. The murmur is really characteristic for an aortic valve lesion. Lungs are normal vascularity with a CT ratio of 5.5. At this age, it is a borderline CT ratio. Up to 4 years, it can be from 5 to 5.5. This is, oh, excuse me. Oh, yes, this is her ECG. And on the left, you can see a very old modality in pediatric echo, a phonocardiogram. This is ECG, and that patient basically was one of my patients during my residency in 1982. And this ECG was recorded in 1982, and that was the second case of that type that I see. So I'm sorry because the ECG is not clear, but let us read the findings here. Excuse me. If you look well, the V1 is shows an RS pattern, and the S is deep, and the amplitude of the S is about 20 millimeter. The V6 shows a QR pattern, and the R is long amplitude, and the amplitude is about 25 millimeters. So R V6 plus SV1 amounts to 45 millimeters, which is an LVH. We used to use the phonocardiogram for diagnosis of congenital heart disease in the era where echocardiography was not available, and where the characterization, accurate characterization of the murmur was important. That is another ECG of the same kind of lesion. Again, in V1, you can see SV1 RS ratio less than 1. The S is much deeper than common. The SV1 plus RV6 is over 40. It's about, now in that case, about 55 millimeters. The axis is leftward. And again, the T wave is abnormal, denoting left ventricular overload. In that case, it is a systolic overload. So we are facing again a case with LVOT obstruction. The murmur is characteristic of aortic valve lesion, and as you guessed, this is a characteristic congenital aortic stenosis. The diagnostic criteria are, again, LV dominance and a normal pulmonary vascularity, one of the group of LVOT obstruction. What is interesting in that case particularly is that, as you can see in her angiography, the stenosis is not valvular, it is a supravalvular stenosis, and that is common in in association with the Williams syndrome. The one I am sure most of us has noted the faces of that girl, broad mouth, smiley face, very depressed nasal bridge, saddle-shaped nose, and frontal bossings with the failure to thrive. Williams syndrome is not uncommon. Personally, I might see 2, 3, or 4 cases per year in association with congenital heart disease, either aortic valve, supravalvular, or coarctation. These are the 3 commonest lesions in association with the Williams syndrome. A small reminder about the causes or the anatomical causes of LVOT obstruction. Every one of us should be very aware about that typical classification. Case number 15. Now we are going into the group of congenital heart disease with cyanosis. A full-term newborn. The age is not specified, but it is clear from the description that we are in the first day of life. So, cyanotic baby, not well corrected by oxygen inhalation, so directing us to congenital cyanotic heart disease. No murmurs, no distress, normal pulmonary vascularity with cardiomegaly. Ambiguous findings, but please look well at the X-ray. This is the ECG of that newborn, 12 hours after delivery. Axis of 120 within normal for age. RS pattern in V1, RS ratio in V1 about 3, normal for that age. RS pattern in V6, SV6 about 5.5 millimeter, normal, until 8 is normal in the newborn. The T wave is upright V1 to V6, and this is the normal neonatal pattern. A small reminder that from birth up to 8 hours of age, the T waves are inverted and they gradually become upright, departing from 6 to 8 hours postnatal and then during the first months. Basically, this is a normal ECG for that age. So, what can be the diagnosis? Cyanotic congenital heart disease with normal lung vascularity, cardiomegaly, and no cardiac murmur. Really, it should direct you to the transposition of the great arteries with intact septum. And why with intact septum? Because if there were a shunt, a significant VSD or an ASD, there would have been some distress or even heart failure. But cyanosis without ventricular dominance and with normal vascularity is really near characteristic. You cannot diagnose TGA on that grounds, but you greatly suspect the lesion. The importance of ECG in that case is that, number one, you as a pediatrician should know what is normal and what is abnormal in first day of the newborn. And second is that a normal ECG does not exclude initially in the neonatal period, a significant congenital heart disease. And third, and this is a little bit important clinically, if this is a cyanotic congenital heart disease, other than TGA with intact septum, abnormal ECG findings would have been observed. And the normal ECG, again, directs more towards TGA with intact septum. So if you see that case, this is an urgent, near emergency case for echo and for transferal, for طبعا balloon atrial septostomy. This is the X-ray of that newborn. Note the very characteristic shape of the heart, which has been very traditionally described as egg on side. Egg on side shadow of the cardiac shadow in X-ray is not specific for TGA. Earlier on, years ago, before the advent of echo, it was considered specific. But from what I have seen, what we have seen all, we can encounter that pattern of egg on side appearance with tetralogy of Fallot and sometimes with Epstein anomaly. Case number 16, full term, same clinical findings, but with a murmur. The murmur is not specific for a lesion, and as we will note, and we should agree upon, that murmurs may be very characteristic of specific congenital heart diseases in the acyanotic group and are not at all characteristic for specific congenital heart diseases in the cyanotic group. In X-ray, there is increased pulmonary vascularity, so there is a shunt, left to right shunt, with cardiomegaly. And this is the ECG of the case. Please take a few moments to review. Axis 0 to minus 30, leftward. The P wave is peaked in lead 2, and note that shape of peaking of the P wave in V1 and V2 and maybe V3 as well. The RS in V1 shows a very large S wave, but the RS ratio is less than 1, which is not at all normal in a newborn. The pattern in V6 is R, big R, small s, and this is not common, not normal in a newborn. And the R in V6 is 18 millimeters, and this is a borderline amplitude for the R wave in V6 in a newborn. I didn't comment here much on the T wave pattern, but you can see that the T waves are upright V1 up to V6. The pattern here is of left axis deviation, left ventricular dominance, and in addition, a right atrial P, pulmonale as we know it. So did someone think of the lesion? Yes, tricuspid atresia. Tricuspid atresia isolated without no associated lesions, especially pulmonary stenosis, will present with cyanosis, definitely, increased pulmonary vascularity, and left ventricular dominance, with evidence in ECG of right atrial dilatation. I like that combination of left ventricular dominance with right atrial dilatation. We have seen it in one of the acyanotic congenital heart disease, the Jerboot types of VSD, and these have no cyanosis. Tricuspid atresia as well, and definitely the Epstein anomaly. Both tricuspid atresia and the Epstein anomaly of the tricuspid valve, I'm talking about the anomaly of the tricuspid valve, are associated with cyanosis, but still we can differentiate between them based on the ECG finding in the newborn unit. Same infant, newborn, full term, soon after delivery, cyanosis, not corrected. Basically, same clinical findings with a murmur. And the murmur is at all not specific. Radiologic findings, normal pulmonary vascularity with cardiomegaly. But look at the X-ray, the cardiomegaly is really significant. One of the meticulous attendees with us now will say that there is a little bit of rotation in the radiologic picture, yani rightward rotation, yes, but it is not significant. And this did not cause that pattern of cardiomegaly. This is the ECG of the case. The axis here is 60 to 90, near accepted, though in the newborn the axis should be more rightward. So it can make you suspect something. The very prominent salient feature in that ECG is the peaked P wave, obvious in V2, in P2, in lead 2, and in V1. It resembles a QRS complex, really, but it precedes the QRS complex. The P wave is not only peaked, but is of high amplitude, about 3 to 3.5 millimeters. In V1, the RS ratio is 0.5, again, not normal in a newborn. And there is a QR pattern in V6, and this is not normal in a newborn. Left axis, left ventricular dominance, and very large P pulmonale. Same findings, near same findings, but the very large P pulmonale in a cyanotic newborn can direct me easily to the Epstein anomaly of the tricuspid valve. The difference between Epstein anomaly and tricuspid atresia in that age, in this situation, is the lung vascularity. But very commonly, the tricuspid atresia is associated with pulmonary stenosis, so it can be associated with normal lung vascularity or even oligemic lungs. The very large P wave suggests always the Epstein anomaly of the tricuspid valve in newborns. I like that ECG, not because of anything except that this is the ECG of the first Epstein anomaly case I have seen when I was resident in 1982 again. And I was taught by my professor, Professor Badreddin, some of the presents here would know him, that this is characteristic for Epstein anomaly. And since then, I can easily pick Epstein anomaly. That ECG particularly, it was a whole ECG, but I got that strip. It was very disturbing to me because I couldn't characterize the QRS complex. As you see, the P wave is so large that it is nearly larger in amplitude than its QRS complex. And I took that ECG to my professor, and at once when he saw it, he told me this infant has cyanosis and has Epstein anomaly. We didn't have at that time an echocardiography in our pediatric department. We didn't have people who were trained in it. And I took that particular patient. He was, I remember, several months. I took him to a pediatric cardiac center in Cairo University, traveling for 3 hours to do an echo study and to confirm the diagnosis, and returned back to my professors telling him that he was right. And ultimately, that patient lived with me until about 10 years. But unfortunately, I don't know his fate later on. A peaked P wave in association with congenital heart disease is characteristic of Epstein anomaly, but is found in tricuspid atresia and as well in association with pulmonary hypertension. Okay, for the case number 18. All right. The diagnosis and admission is very clear. Dr. Mervet Abu Mati is with us, and she will be happy to admit that case and to manipulate him easily. He presents with an SVT. He is 1.5 years old. He received an intravenous kind of medication, beta blocker or else, to abort his SVT. And after that, he had that ECG. Excuse me. No, this is his ECG during the episode. I'm sorry. So, as many of us here would put a differential diagnosis, we have a broad complex tachycardia with no evident P waves, though in lead 2 there might be a debate about the presence of a small P wave. However, this is an ECG of ventricular tachycardia. Okay, an infant with ventricular tachycardia, uh, treated and aborted tachycardia, should direct us to a few underlying congenital heart diseases. In that case, that infant had a cardiac tumor, not a rhabdomyoma, a fibromyoma, or other tumors. Rhabdomyomas are uncommonly a cause for ventricular tachyarrhythmias, but maybe. But the message is whenever I face ventricular tachycardia in infancy, I should think or consider cardiac tumors as one possibility. But again, ventricular tachycardia in infants may be underlying a long QT syndrome, and thirdly, in prevalence, an arrhythmogenic right ventricle. There are other uncommon rare causes for VTAC in infants, but these are the three most common congenital heart diseases. If we consider long QT syndrome a congenital heart disease, and it is put in textbooks under that group classification, so pediatricians should think of those three conditions. And the differentiation is easy by ECG, echocardiography, and cardiac CT. This is case number 19. I hope I'm not going fast. And if I'm going fast, please, Dr. David or Rana, halt me down here. All right. Infant with heart failure, severe to cause cardiogenic shock. Desaturated, cyanotic, failure to thrive, non-specific murmur, very non-specific, and we agree upon that. And in chest X-ray, which we do see in that slide, there is cardiomegaly, non-specific, not having a specific pattern, with evidence of pulmonary venous congestion. And I intended to get this pattern in the presentation. I talked originally in my introduction about the three classifications, the three groups of congenital heart disease based on radiologic classification, with increased, decreased, and normal pulmonary vascularity. But I mentioned few other uncommon types of pulmonary vascular patterns in association with congenital heart disease. One of them is pulmonary venous congestion rather than arterial venous plethora, pulmonary arterial plethora. Can we differentiate between both conditions or both terms in plain radiology? Yes, if we have enough experience and are meticulous enough. It is not the spectrum, the focus of our presentation. I told Rana once we can talk about radiology in congenital heart disease. So this is the case, and this is his ECG. 3 months old. Axis 90 to 120 within normal, accepted. RV1 25 millimeters, very large amplitude are in V1, denoting right ventricular something. And the hallmark or the very characteristic of that ECG is that the RS complexes are being diminutive, departing from V1 to V6. this very characteristic pattern, the right axis, near right axis, and the right ventricular dominance with diminutive QRS amplitudes is not characteristic, but directs us towards that diagnosis. Pulmonary venous congestion is not a hallmark, but is a very prominent criterion which can help you to suspect the hypoplastic left heart syndrome before having the echocardiography. All right. Diminutive RS forces in precordial leads in congenital heart disease occur in dextrocardia, definitely yes, hypoplastic left heart syndrome, and in some cases with the corrected TGA. Again, if you find such a feature in your infant or newborn with congenital heart disease, you can approach the diagnosis. Case number 20. This is an interesting case, and we encounter that case at least once every month. So this is a 2-year-old boy or a girl with repeated wheezing chest since infancy, and any pediatrician would make easily the diagnosis of bronchial asthma in such conditions and give a nebulizer therapy. In our case, number 20, the child responded to nebulizer treatment, but not in a good way. Upon admission, there was distress concordant with asthma, wheezing, and fine crepitations concordant with asthma. The heart sounds were weak, with a soft pansystolic murmur over the cardiac apex. In that situation, the pediatrician should evaluate and reconsider the diagnosis of asthma. Yes, the X-ray shows cardiomegaly, diffuse, non-specific. حاجة زي يعني it resembles the flask-shaped heart of pericardial effusion. And really, I will tell you a small story when we were resident, but after that case, really it is confusing radiologically with pericardial effusion. The salient feature in that X-ray, again, is the pulmonary congestion. And I intended to bring that case just after case number 19, because both present with pulmonary venous congestion. The pulmonary venous congestion is more prominent in that X-ray on the right side. And I think we'll come across the causes in congenital heart disease. This is the ECG of the case. All right. I think most of us were noted the striking appearance of small QRS complexes amplitudes in the peripheral and in the precordial leads. This is what we call in ECG microvoltage. And obviously, this is a characteristic, typical case of dilated cardiomyopathy, usually as most pediatrician most pediatric cardiologists encounter misdiagnosed in early infancy in early childhood as bronchial asthma. The very characteristic diagnostic finding in that case is the microvoltage in ECG. However, let me bring again the sign of pulmonary venous congestion in X-ray, it occurs in association with the cases of cardiomyopathy presenting with heart failure, like that case. Dilated cardiomyopathy are a heterogeneous group. The ECG abnormalities in most of the cases are those in front of you. Microvoltage, intraventricular conduction delays, and definitely Q waves in V1 and V2, V4, which is a little bit abnormal. Very common. I return to the X-ray and the finding of a large heart resembling pericardial effusion, flask-shaped heart, when we were resident and we didn't have echoes and we encountered such cases. We were very confused whether this cardiac enlargement or cardiac shadow enlargement in X-ray, whether it was a cardiomegaly or a pericardial effusion. And we used to perform many maneuvers and radiologic pictures to differentiate between effusion and cardiomegaly. And in most cases, we succeeded to make a diagnosis. When the echocardiography was introduced in '84, we were very much relieved and we quitted such radiologic maneuvers, which were very tedious. Case number 21, 12 years boy. As you see, this is not common in our countries. We very rarely see patients with high altitude pulmonary edema. But I guess those working in Sinai may encounter such cases because many people live in high mountains in Sinai. But we are all aware about high altitude pulmonary edema, which is a transient occurrence and resolves when the child returns to the normal, usual altitude where he lives. Anyway, he was admitted to hospital during one of such episodes. And this is his ECG. 12 years old, remember. The axis is 90 to 120 in a 12 years old. This is borderline abnormal. The P wave amplitude is 4 millimeters and peaked in lead 2, in V2 and V3 as well, and is biphasic in V1. As we can measure, the P wave is 4 millimeter. In V1, the pattern is an exclusive R, Q and R, abnormal. And there is T wave inversion V1 to V6. This could have been normal in a newborn or a very young infant, but in a 12 years old child, this is not normal and denotes right ventricular hypertrophy and strain. The P wave denotes right atrial hypertrophy. Such combination is definitely a criterion for diagnosis of pulmonary hypertension. And in our case, the diagnosis is a high altitude pulmonary hypertension. Um, the very important diagnostic approach is to perform a cardiac catheterization. In that case, it was the pulmonary artery pressure was high, but the nice thing about such cases is that they resolve easily, usually with pulmonary specific pulmonary vasodilator therapy, in contrast with the congenital heart diseases with pulmonary hypertension. And after 6 months of such therapy, the pulmonary artery pressure dropped. Definitely, it would not drop unless the child or the patient is relocated to the sea level. All right. Case number 22, 9 months old. All right, I am very focusing in that case on first on the clinical presentation. Sudden, within seconds or minutes, previously healthy, then sudden irritability. In pediatric field, sudden irritability directs the pediatrician to many diagnoses, including medications, poisoning, head trauma, intracranial hemorrhage, and disease conditions. The second emphasis focus is that the infant looks healthy with no cardiac murmurs and that the heart sounds are weak. Weak heart sounds in an infant with possible congenital heart disease should direct us to specific groups of congenital heart disease, including the cardiomyopathies. Third point is that the pulmonary vascularity is normal, so we are not facing a shunt lesion, we are not facing an RVOT obstruction. We might be facing an LVOT obstruction. This is the ECG of the case. Again, he is 9 months old. Not a common ECG. We do not see such cases very commonly, once every few years. The axis is 30 to 60 degrees, deviated leftward شوية, and there is a deep Q in lead 1, AVL, V4, 5, and 6. The ST segment is raised in V4, V5, and to some extent V6. The amount of raising in V6 is not more than 1 millimeter, so it can be accepted, but in V5 and V4 is more than 1 millimeter. However, the extent of raising alone cannot make the inclusion or exclusion of ischemia or abnormality unless there are other pathology, and right here we have an abnormal Q wave. Yes, these findings are consistent with acute myocardial infarction. And this explains the sudden irritability, sudden pain, chest pain. And whenever we meet such cases, we should think of the Al-Kappa anomaly. Not common. I'm not sure when every one of us have seen lately such a case, but it has been maybe 3 years since I have seen one of these cases, and without myocardial infarction. QF abnormalities in association with congenital heart disease should direct you, pediatrician, to Al-Kappa, myocardial infarction, corrected TGAs, very important, and some of the forms of dilated cardiomyopathy, as we have seen. And the QFs mostly are in the left precordial leads in such cases. Acute myocardial infarction in pediatric age is not common at all. But whenever there is infarction, we might be encountering one of these groups of conditions. Each of them is not common. And this is a message for the general pediatricians. All right, I think I will make it the last case, the case number 23. Please read. So this is a full term, newborn, aged 2 days, admitted because of transient tachypnea of the newborn. He is healthy and acyanotic with normal pulse, no murmurs, but with distant heart sounds. The pediatrician or neonatologist, as occurs usually, had made an ECG. And this is the ECG of that newborn. The axis is 180, 80 rightwards. The P wave is inverted in lead 1 and not in 2, but inverted in lead 1 and upright in VR. And the pattern in precordial reads is RS with diminutive RS amplitudes from V1 to V6. So right axis and right axis deviation of the P wave. This is important. And such findings are very consistent with dextrocardia. The hallmark of dextrocardia based on the ECG is a P wave inversion in leads 1 and 2 with a right axis deviation of the P wave. Dextrocardia in infants or in pediatric medicine is either isolated or in combination with congenital heart disease. Usually, isolated dextrocardia occurs in combination with congenital heart disease. But dextrocardia in association with situs inversus is not associated usually with congenital heart disease. This is not a very strict rule, but it is a common occurrence. When you see a patient with dextrocardia after making the diagnosis based on that ECG, you have to perform another ECG in the inverted, lead placement to make diagnosis for ventricular hypertrophy or true axis deviation, pathologic axis deviation. All right. I think it has been an hour and or so. Okay, let me see this case with you and make it the last case. Full term, again admitted with transient tachypnea of newborn, age 2 days. All right. He looks well, except for increased respiratory rate, no murmurs, normal heart sounds. I forgot to tell you that the case number 23 had weak heart sounds, which were weak because they were distant. The auscultation was on the left side. So, يعني, whenever you see weak or you auscultate weak heart sounds, think of going to the right side to detect whether they are better heard. So this infant has no cardiac murmurs with normal heart sounds, but the X-ray showed an abnormal cardiac shadow, as you can see, with normal lung vascularity. The question is, you perform an ECG of this for this newborn, and we will see it. The question is, after doing that ECG, would you perform an echo study for that newborn? I will make it easy for you. The electric axis is 150 for a 2 days old newborn. This is a normal axis. The R voltages in chest leads are dominant in V1, V2, V3, V4, and the T wave is biphasic in V1, V2, V3, and maybe V4, and then upright in V5 and V6. This is a normal neonatal pattern. So again, the pediatric cardiologist should not only know abnormalities, should know normal variation based on age. The radiologic appearance in the presence of this normal ECG is that of a big thymus shadow. Maybe once every week or twice every week, a newborn is referred to me for an echo study because he has this clinical combination. I usually call back the neonatologist and teach him how to evaluate a chest X-ray with a large thymus, how to evaluate an ECG in a newborn and know whether it is normal or not. In half of such cases, when I'm confident that there is no congenital heart disease, I usually refrain of doing an echo study and send back the patient to his pediatrician. In other half of the cases, I am forced to do an echo, though I am a little bit very convinced that there is no congenital heart disease. The reasons why I'm forced is ethically towards the pediatrician who sent the infant. Sometimes is that the parents are so worried. So I usually need a document to tell them that the infant has nothing. And some few cases, I, by bad luck, hear an innocent murmur, which may be underlying congenital disease, so I'm forced to do an echo. But usually this combination of findings in a newborn are not an indication to do an echocardiogram. The arrows here point to what we call the thymocardic notch. I will remove the arrows. You can see easily a notch between upper mediastinum, the thymus shadow, and lower mediastinum, the cardiac shadow. This is very characteristic for a thymus shadow. I think I end here because we have passed our time. I thank you for listening. And if there are comments, I'm ready to be there. Thank you very much. Thank you, Dr. David and Dr. Rana and the organizers.
Thank you, Dr. Salah. So great to have all of this great review of lesions and presentations, basic testing. That's so informative. You have so much experience in this area that it's great to learn from you. I think we have just a couple of minutes for questions. If anybody has them, please put them in the chat or unmute. Let's just take a minute to see if there are any questions. when people are quiet at the end of a talk like this, I don't think anyone needs to conclude that they are disinterested. I think we all had learned a lot about Dr. Salah. Really, I have no questions, but I take with me many lessons from these excellent cases. Let me just ask Dr. Rana, Dr. Rana, do you have any comments before we wrap up? Thank you so much, Dr. Salah. Very nice talk.
Thank you so much,
Thank
Prof.
you,
Salah,
Dr.
for
David. And before yes, go ahead, Rana.
No, it's okay, Dr. Salah.
I thank you very much for that opportunity. I thank you, Dr. David, and thank all the group for their a great effort to bring pediatric cardiologists and especially electrophysiologists together. I'm proud to have been with you. And I just noticed that I was closing my video, so I apologize. I didn't intend to disappear from the screen. And this is the problem with online lectures. And as Rana knows, I usually prefer to be with people, interact with them. So thank you very much. Rana?
Thank you so much, Professor Salah, for such an interesting discussion. I think everyone was so involved in the case discussions, the ECGs, the X-rays. So don't worry, even when the video was off, people were already putting their comments in the chat. So it looks like we were already so much involved. Thanks so much for your time. Being online helps us disseminate knowledge to people elsewhere. So hopefully we did this.
Okay, Rana. All right.
There are no more questions in the chat. People are just thanking you for this session. As Professor Salah said, we should think about the congenital heart disease as broad terms, like RV or LV dominance, cyanotic or acyanotic. And this is a very interesting way to just put a few differential diagnoses in our mind prior to sending the patient to echocardiography. And ECG has helped us so much, but as Dr. Salah said, it's so important to know the normal before diagnosis of abnormal findings. And this was very well illustrated in this session, Professor Salah. Thank you so much for everything, for your time, and for the nice case discussions.
Thank you.